there are situations that is unfavorable for the implantation, there are two reasons for unfavorable implantation. I'll explain you. So now we are entering into the sixth part. No IVF ICSI end-to-end, or say no IVF no ICSI. So this I am constantly emphasizing in the start of every video. It's on the well-wish of the couples. I'm seeing couples in their position, myself in their foot. That is the end reason why I'm delivering this speech. Why I'm trying to make the couples understand in depth of clarity. They should become competent to an embryologist and clinician because they are having that pain of infertility. They are having that financial challenges of infertility. So they should get the maximum benefit by rectifying their own problems and taking the right decision, thereby improving the results and enhancing their success rates. So now let's go to the sixth topic. It's called fresh versus frozen embryo transfer. What is this fresh and frozen? See, when you are undergoing a stimulation in a particular month, on a day 2 you are undergoing stimulation by 8 to 12 days, you are getting injections, either agonist or antagonist protocol. Then on a particular time you are undergoing the pickup procedure. Then IVF or ICSI is being completed. From now onwards we'll go through morely we can speak about ICSI. ICSI is completed. Then we are culturing the embryos in the IVF lab in an incubator for 3 to day 5 embryos, and maximum number of day 5 is we can consider. So now what are we going to do in the next step? On the day 5 you are having some number of embryos, X number of embryos. Can I transfer the embryo on the same month? If I go through, it's called fresh embryo transfer. If there are situations that is unfavorable for the implantation, there are two reasons for unfavorable implantation. I'll explain you. In case if the endometrium or the uterine factors is unfavorable for implantation in that same month of the stimulation, then we can freeze the embryos and transfer it in the subsequent months, anytime after second or third month. So this is called frozen embryo transfer. So now you understood there are two methodologies. Either you can undergo fresh embryo transfer or a frozen embryo transfer. So now what happened is, I told you agonist protocol can have these chances of OHSs or something. Then we have to, OHSs will get aggravated by getting a pregnancy. So when your OHS is a deadly condition, fatal condition, risk for the life risk for the women. So in that impending situation, when you get a pregnancy, it is all the more worsened. So when you are having any potential to develop OHSs, number 1, kindly avoid fresh embryo transfer. So even your clinician will not recommend or will not do that procedure because she has to carry you if you develop OHSs. It's a headache. So no, that is one thing. Second, if the uterine endometrium, the inner wall of the uterus, which is going to receive that embryos and going to favor that implantation of the embryos, that endometrium, if it is in the optimal condition, which is called 8 to 10 millimeter of growth, then it is called an optimal time you can transfer. If it is 5 millimeters, on the other hand it is more than 13-14 millimeters, then it is very unfavorable to get the implantation. So better freeze the embryos. This is how we have to try. So these are all the factors like uterine factors, endometrium factors, protocols, and everything we need to take into the consideration. And we need to understand this is a very common terminology. Something, even research is going continuously in these areas. Embryo and the endometrium. Embryo-endometrium. Synchronization. That is very, very, very important. It's all completely divine. It's completely nature. So, unless you may have a best top quality embryos and the endometrium is very perfect, but still you are getting negative result. So then the technology called ERA has come into the play. See, technology can grow like anything, but you cannot overlook the nature. So that synchronization is very important. So endometrium embryo synchronization has to be very critically analyzed by the clinicians and the embryologists and they should be really properly analytical. Say, whatever I do, endometrium is not growing beyond 6 to 7 millimeters. I have to take a call. If I'm having 4 embryos, out of which 2 are A quality embryos and 2 is B and C, average embryos. This time my endometrium is not very favorable, less in thickness. Transfer the average embryos. Keep the reserve, the good embryos. Maybe you can think of some alternative medicine treatment to make the endometrium favorable, stem cells. So many treatments or modalities are available. So this is how the analytical should take place. And after listening to your video, now you are understanding that clarity. What is my endometrium thickness? Is this thickness sufficient to get that implantation, or what type of embryos are going to place? How many embryos are there? How many are grade 1, grade 2 and grade 3, grade A, grade B and grade C? So are you going to reserve some embryos for the future cycles? If I get positive, for the second baby, if I get negative, for the second attempt. So all this clarity, you can communicate with your clinician and your clinician will feel happy. The opposite person is blindly listening to me or having an understanding and we are gelling to each other. If a result positive, we are happy. If a result is negative, we knew to some extent what could be the contribution for this result, negative result. So always understand. If there is an OHSS or an unfavorable endometrial thickness, then better to go for freeze-all. Nowadays, majority are going freeze-all techniques, transferring the embryos at a subsequent months, second month or third month. So fresh transfer can still be attempted. If you have surplus embryos and the endometrium is really on a favorable side, why not you try on child? By this, you are getting an earlier pregnancy and you are not wasting anything. So these are all the ways you have to analyze, you have to see the situations. Based on the particular situation, you choose the transfer, fresh or frozen. But on a broadly speaking, freeze-all, frozen embryo transfer is a better choice. And always go to your individual clinical situation and take the decision.